Welcome to Dev&Doc. This is a podcast where developers and doctors join forces to deep dive into artificial intelligence in healthcare. My name's Josh. I am a doctor and AI clinical researcher. I am your co-host.
And I'm Zeljko. I am the developer side.
So today we're going to talk about a very interesting topic, which is forecasting the future. Can AI predict the future of a patient timeline? In order to understand that, we need to first delve into what diagnosis and prognosis is. So actually, before we begin, I wanted to ask Zeljko, as a developer who has been working with clinicians, what do you understand about the job of a doctor? Like, what do you think is the main things that we do?
Maybe not the best example because the doctors I've worked with a lot of them are very much on the research side or do a million other things next to also being a doctor or next to their clinical duty. But I mean, I don't know. I would just say that job of the doctor is to fix people. That's my understanding. Like, a mechanic fixes a car, a doctor fixes people. That's my interpretation.
That's a very developer-like answer. I mean, we do more than fix people. I mean, for one, there's like the human touch, which is very important because patients, as far as I know, don't want to just talk to a cold, heartless robot. But yeah, look, the key aspects, in my opinion, is diagnosis and prognosis. That's essentially what separates doctors from the other clinicians, really. And that's what we go to medical school for. So we study a lot about how to diagnose people. And once the diagnosis has been reached, prognosis. So how do we prevent this disease from happening again, right?
Yeah. So, okay, how do you diagnose someone? Like, what is important? How do you approach that?
So diagnosis is very much a science as well as an art, but it's something we've learned in medical school. So we do a thorough history and examination, and we follow something called the Cambridge-Calgary framework. And without going too deep into it, it's essentially trying to tease out every aspect of a patient history, why they've come in, what their past medical history is, what drugs they're on, family history and their social history, so what they're like normally, and what kind of habits they have in their life that could predispose them to certain conditions. So for example, if they drink a lot of alcohol or smoke a lot of cigarettes, then they're much more likely to have certain diseases like heart disease or liver disease. And all of these help formulate what is the most likely diagnosis at the end of your consultation. We also perform a clinical examination, which is just going through different systems, head to toe, listening to the heart, listening to the lungs, performing neurological tests, depending on what they've come in with, to try and refute or confirm our differential diagnosis. And then following this, we order investigations and tests to further confirm or refute that diagnosis in our head. So this is what we've been learning in medical school, and it's something that all doctors practice. And then once you have reached the diagnosis, let's say after someone's come in with a seizure or a fracture or a heart attack or a stroke or even a depressive episode, the next question is, what does that mean for the patient? How do we, number one, treat it? But number two, how do we prevent that from happening again in the future?
So you were just mentioning like a lot of that you learn in the medical school. And my question is really like, how much of that diagnosing and prognosing do you learn in medical school, and how much is learned once you start being a doctor, once you start your training?
That's a great question. I think it depends on the medical student and how much kind of clinical exposure they've had and their learning experience and framework. I think for me, medical school is very much about setting up the framework and the basic pathophysiological understanding of the human system and what can go wrong. We did, of course, get assessed on history taking and examination, But I think it wasn't until I started practicing that I gained a lot more fluency and understanding about how to do it well. Because you could just go through a checklist and ask a patient every single thing under the sun, and you probably will get to the correct answer. But I think as you get more experienced and more skillful, you start to understand how to curate the history and the examination to the patient and their presentation. So, for example, if a patient comes in with abdominal pain versus chest pain, you would approach that very differently. The questions you would ask would be very different. And there are certain questions we call red flag symptoms. So symptoms that are indicative of something sinister or deadly going on. And it's very important to ask those questions. So depending on what they've come in with, you have important positive questions to ask, but also negatives. And I think that a lot of that comes from experience. So very much, I'd say the majority of what I've learned is in practice.
I'm asking these just because, as you know, a lot of the current large language models that people are using in training for healthcare, a lot of them are focusing on multiple choice questions or questionnaires or quizzes or questions and answers or something like that. So stuff that is all on the theoretical side maybe. So none of it is, or very little of it is the stuff you learn in practice. Most of it is the stuff you learn from reading books.
That's very true. And yes, because in the exams, we covered this in the previous episode, the questions in many ways already, they either list out the signs and symptoms that the patient has come in with and then ask you to reach a diagnosis, which is not really the real world. A lot of the skill and the art and the difficulty is actually knowing what to ask the patient and gauging their understanding. Because if I had a patient who was very highly educated and was very well read and knew about their conditions and how to convey what problems they were having, that's very different than treating someone who is, let's say, homeless or an alcoholic who didn't get that same chance to have an education. Like, they may not be able to express themselves in the way that they want to, or they're not sure what information I want from them. So my approach to those two people would be very different in how I speak to them. Like, even my word choice and my body language, I usually adapt depending on the patient that comes in. But I would say that the large language models that are trained on textbooks or or tested on medical school exams probably are not reflective of what would be happening in the real world. And that's why a lot more kind of real world testing needs to happen. And we need to be examining these large language models not just on exam questions but on real world scenarios, and then actually implementing them into the healthcare setting to actually test them to see if they can actually function when they're given more complex notes taken from hospitals.
No, yeah, I think this is this is exactly right. The only I'm not saying like, everything we are doing with the current large language models and the way we train and test them, all of that is wrong, and that does not benefit us, because I'm doing that also myself.
Yeah.
Like, and together also with you, we have created the NHS large language model that is basically doing question answering. So you do have to start somewhere. But I'm mainly, like, I was asking these just to understand, like, the road in front of us is still like very, very long. And not just that the models have to be applied in a real world scenario, but we also have to change the way they are trained. You want to train them on real world data so that they can be applied to real world data. So I think there is quite a bit there to still be done. But there was one other interesting thing you were mentioning. So you were mentioning that depending on the patient, depending on the person, you will approach it very differently, and it is how you ask the questions. It is you have to adapt everything basically. My question there is there time to do that? Because I'm constantly seeing, like, as you said, I'm working with doctors quite a bit, and the main thing I see, everyone is under immense pressure. There is no time to do anything. It is like there is hundreds of patients per day, and you have to run around, do all of them. Do you really have the time to do that for every person?
I would say it's getting increasingly difficult. And I think that's why experience is so important. Because I think with time, you know what kind of patient you need to spend more time on. And, you know, for example, certain patients, if they're more elderly or have dementia, then you will know that they may not be able to communicate with you very effectively, in which case you need to speak to the family. Time is getting harder and harder to come by in the NHS. There is more and more patient burden, and it's getting busier and busier. But I don't think that's an excuse for not carrying out a, safe and proper history and examination. So I always try my best to still do that.
Yeah.
Sometimes you can take shortcuts, but that comes with experience. And if you don't do it right, you can end up missing something or missing a diagnosis or maybe ordering the wrong tests. So it's very important. But I think in answer to your question, yes, we do try our best to deliver this, an optimum level of care for each patient, even if we are stretched for time. Sometimes we end up staying a bit later. Sometimes to be safe, we might practice in a safer way. So if we aren't sure, it's always probably better to keep the patient in for more investigations and more review rather than sending them home.
Yeah, no, I mean, you mentioned we should not use time as an excuse. I don't think time is an excuse. I mean, if there is not enough time, then simply there is not enough time. Not much you can do again, to fix that. But I'm also asking this again just because this is a place where AI can jump in. I think the main purpose of AI, at least initially, should be to free up some time for doctors, to make some time so that they can focus on the more important stuff and leave the less important, annoying, boring, irrelevant stuff to an AI. And in fact, this is also where I wanted to ask, if you were to look at 1 week of your clinical duty, like an average week of you and maybe even just a general doctor, how does that look? If you could make a pie chart out of that, how is your time distributed? What do you spend your time on in a typical week?
So the best way to explain it is probably just to go through a normal week in working as a neurology trainee. So I would say my most frequent day is something called the ward day. So that's working on the ward, which is where all the patients have to stay for either treatment or investigations. So normally this starts with a morning meeting. So this is with all the nurses and the wider multidisciplinary team. So physiotherapists, speech and language therapists, etc. And we all sit together and we go through the highlights of the night, any deterioration or any problems during the night. And we also run through the kind of big picture plans for each patient. The next thing we do is something called the ward round. And this is a very historical thing. You go around in the team, usually myself. So I'm a registrar, so I'm kind of mid-senior level. And then the consultant is there, as well as the other junior doctors. So that's the senior house officer, and the foundation doctor in the UK. Basically, just doctors from all different levels of training, and we go around together as a group, and we look through each patient's notes. We run through everything. We revisit the history and examination to see if there's anything we've missed. And each day, you basically just get a full review from the team, and we push forward the overarching plans. We treat any problems that may arise. So that's the ward day. So after that ward round, that usually takes a few hours. The remainder of the day is carrying out those plans. So let's say we've seen a patient. Let's say they were very, let's say they had a seizure overnight and now they're really drowsy. We'd be really concerned. So there's certain things we have to do. We need to take urgent blood tests. We need to take them urgently to the CT scanner for a head scan. We need to contact the family. So after the ward round, different individuals from the team may break off to carry out those important tests and phone calls and tasks. Does that make sense? So that's kind of the most frequent ward day. The other kind of day is when you're on call. So this means that depending on your specialty, you're in charge. You're basically the gatekeeper of that specialty. You decide if other patients should be admitted under you, and if anyone has a question for your specialty, they will call you. So this is the kind of day that normally is a 12-hour day, or maybe 24 hours if you're in the US. You get bombarded with phone calls from left, right, and center. Calls from the GP, calls from the emergency department, calls from other teams asking for your expertise, and different hospitals, different teams saying, oh, we've got a patient that we think should be admitted under you, so they should be on your ward. So in which case this is a neurology ward. So if someone's having very difficult to treat seizures or something very specialist, like multiple sclerosis, inflammatory demyelinating disease, then they will call you and say, can we move them to your ward? Because they're probably better off being taken care from you and your nurses directly, rather than you providing either advice over the phone or just reviewing them, after your ward round. Yeah.
How does the giving advice look like? Like, does someone call you and it's just like, oh, I have this patient, then describes the patient and then you give advice? Like, what's the process basically there?
Yes. So very much like the Calgary-Cambridge framework we talked about for history taking, there's also many frameworks for relaying information over the phone to another clinician. So one of them is called SOAP, or one is called SBAR. These are all acronyms, but essentially it's the situation, the background, the assessment, the recommendation. So they can describe the patient to you, tell you the background, tell you what they've done so far, and then recommendations, or in this case they would ask for advice. Okay, we told you the story, this is what we've done, what do you think we should do next?
How, that seems like it will take too long, or is that just a very brief summary? Because it seems like, I'll tell you about the history of a patient can take 3 hours.
Yes. I mean, this is one of the limitations of language, I guess, or of human communication. We can only convey information so fast. And that's why there is this framework to maybe try and streamline this process. But you're right, it can take quite long. Some phone calls would be very quick. They'll be like, they can say, oh, this patient had a seizure. They've had a history of seizures. We really want to start them on the medication. We've done all the relevant investigations. What do you think we should start? So that's quite easy. I can just tell them. There are more complex ones. And for those, what I do is I try to get the patient number. So I bring them up on my system as well. And then as they're talking to me, I would try and read through the relevant patient details. And that really comes of experience. So depending on what they describe to me, I know where to look. And important things are obviously blood tests and head scans and previous letters from our department. So if they have seen by a previous neurologist, I'd be very interested to see what opinion they had previously.
Okay, and like on average, how long does that take? I still cannot place it in my mind. Like, is that still 5 minutes, half an hour, 2 hours?
Let's say the on-call shifts last week, let's say over 8 hours, I probably had a phone call on average every 15 minutes. So, low 30 to 40 phone calls during the day. And they could range from maybe 2 minutes to 10, 15 minutes. There's a big variation. And it also depends, there's so many small things. If a clinician is calling me and they ask, and they can't answer me, or they're saying things which I think are incorrect, or I don't think they're taking the history and examination to the depth that I want them to take, then that gets very tricky. I will have to ask them to either go back and check certain things, or if I'm really worried, I might have to go and review the patient myself.
Oh, okay. Again, I'm like, most of the things I ask is simply trying to understand where is it that you spend most of your time, because I think attacking these fields from the side of AI should really go via the where do you spend most of your time. That can be automated. Of course, some things where you are spending most of your time, I know it can be diagnosing patients and thinking about the patient. Some that should not be automated, at least not yet. But now try to find like what's the place you spend most of your time that can easily be automated, or at least where AI can help. Doesn't have to be automated.
Yeah. So I'll tell you what can definitely be automated, and that is so each time I see a patient, either on the ward round, which we talked about, or if they request me to review a patient on the ward or in the emergency department, I would say probably my approach would be, I'd say around 20% of my time would be reading up on the patient, just priming myself, reading up what's happened to them. That takes, would be about 20%. So let's just say 10 minutes-ish. And then the actual patient interaction, the history taking and the examination, that would be maybe 50% of the time. Around 20 to 30 minutes. And then I'd say documentation and kind of talking to other specialties and ordering investigations make up the rest of the time. So a lot of the time is actually taken of me typing up what I've done and then going through this clunky system, electronic health system, trying to order the tests. And it's never simple. So a lot of the tests I order, I need to call the radiologist. So let's say I wanted an MRI scan of the head because I'm worried about a brain tumor. I have to call the radiologist if I wanted it to happen quickly. They have to vet the scan, so I have to give them the story. And depending on the radiologist, sometimes they may be like, oh, that's okay. Sometimes they'll have more questions. Once they vet it, then I have to call the radiology department to ask them what time the scan can occur. And then once they've told me, I need to run back to the nurse in charge of that ward and tell them, okay, we've got a scan booked for this gentleman at this time. And please, can we get things arranged like, manage his pain, or a lot of the time they'll need cannula, so intravenous access. Because if you use contrast in the scan, they have to give it through the veins, and we have to do that. So there's a lot of running around and trying to speak to different specialties. I feel like this could probably be automated as well. I'm on the phone so much, and a lot of the time I'm just in a queue, just waiting to talk to someone. This could be, this time could be a lot better used actually seeing patients.
Yeah, but see, that part I think is very hard to automate. Like this initial, when you are saying like, oh, I want an AI that is taking down the notes, or I can just talk to it and it will organize the note and just have something nice. I think that it's one thing and one place where you need to apply the AI. Like it is a very straightforward, simple process. You are talking, it is writing, done. There is no other components. But when you're talking about the second one, where you are calling 7 different people, where it depends on the availability, where it depends on any other patient, or even the state of your patient and the state of everyone else in the hospital, almost, it gets extremely difficult to automate that. And I don't even think that is really going into AI. I think that's simply going into a good IT system where you don't have to make 100 calls, but you can click a button and then have the rest done. But I don't know. That part also goes, once something becomes very simple, then everyone can always do it. I think there is also something in the part that you need to make the call. You need to do all of that process. The moment it becomes like I click a button, I'll just click the button much easier than do the whole other process. I don't know.
I wish there was like an Alexa or Google Home where you can just say, okay, Alexa, I've seen this patient. They've had head injury. I'm worried about a bleed. I'm the neurology registrar. I want to get the scan vetted. Can you please just tell the radiologist if there's any problems? Let me know. If not, book it. And then and then send me a message of the time that this can occur. This is doable. I mean, none of that is difficult to do, really, right?
No, that is true. The only thing is, like, let's assume we have done this via GPT-4, so ChatGPT. You give it the patient's history or whatever the current state, and you say, oh, I want you to contact the radiologist and I want you to get this approved. It is also, you have to be careful, because if the only goal of the model is to get it approved, it will do everything it can to get this approved, no matter what it takes. Like, your goal is to get it approved as fast as possible. So it can go to the radiologist and be like, okay, this guy's dying, we need this in 5 minutes. Sure, that will work, but maybe the guy is not dying. And also, like, it becomes also a bit, I feel like we are solving problems that we have not in the right way. We are solving problems by patching them and creating more problems, because let's assume we have replaced we have replaced that system we have replaced the part of you that is making that call to the radiologist, and now it's done by Alexa. But the radiologist also replaced himself with Google or Siri or something. And then you have Siri and Alexa talking. And you just created more work for basically nothing, like for something that should be, I think, solved in a maybe different way. So there is
interesting. It's interesting what you said. If you had, you're saying if we train an AI whose sole purpose it is to get scans approved and vetted, then that it would theoretically say things which may not be true, or over exaggerate things to get scans approved. I mean, it reminds me of that. Is it like there's a paper clip philosophical idea where if you create an AI whose sole purpose it is to just make paper clips, it could actually end up being, like, it sounds like a really harmless thing to do, but it could actually end up doing a lot of damage theoretically this is going into sci-fi now, but if it siphons all the Earth's resources and like destroys everyone else, and in order to make as many paper clips as possible.
But
it just reminds me of that scenario.
That is also like one of the fears of why you are afraid, or why people are afraid of AGI, of a robot apocalypse or something, just because if the sole purpose of that Terminator or something is to advance humanity, maybe the best way to achieve that is by getting rid of half of them, and then the other half will prosper. So that's it cannot be like one task and then do that as good as possible, because I think it gets a bit messy. But in any case, what I want to just say with this is, like, some of these things should not be automated using a large language model. I think you need to go back to the core of the problem and try to understand how to. So, because here I don't think, in this case of calling the radiologist or something, I don't think AI is needed. Or if it is needed, maybe it's there to summarize the patient's history and just send it to the radiologist so that it's easier to review.
Yeah, so I think what I described in the first 5-10 minutes before I see the patient, I read through the notes and I try and prime my brain on what's happened in the past. That would be really useful, actually, to have an AI to be able to summarize the patient history to me very succinctly. Because it's, depending on the patient, they could have a lot of notes, really a lot. Historically, if back when I worked in a hospital that used paper notes, they would have, massive reams of notes, literally 5 folders worth. Each folder would be kind of several encyclopedias high. And, imagine trying to troll through that and see what's been happening. It's impossible.
I'm really thinking, how do you do that? How do you read through a medical history of a patient that comes and has 2,000-3,000 pages of history? What do you do?
Yeah. You have to be selective. And usually it helps if the hospital has a good infrastructure. So, for example, I'm using a neurological example because I work in neurology, but I would try and filter the letters by neurology clinic letter headings. So, in which case there will only probably be a dozen. I could also, some things I know would probably not be relevant. Like if someone came in with a seizure recently or a head injury, I know it doesn't. I don't need to go back 50 years in the past. It doesn't matter what happened in the childhood. So I'll keep things to more recent time. And then usually there are certain documents that are more useful than others. I think we covered in the past, there are documents that are very much copy and pasted from other notes.
Yeah.
But there are certain documents that are quite good and reliable as to what's actually happening. So for example, to figure out what medication the patient's on, usually I'll go to the GP system and just literally look at what was given. So not even what they've typed, but I'll just look at the dispensing history, because I know that's been dispensed, I know that's been given. Whereas if you look at the notes, there's a lot of erroneous data. They might say the patient's on this medication, but they're not actually taking it.
Okay, so from my understanding of everything you said, the biggest thing or the biggest part where you're wasting time is reading through a patient's history, trying to understand everything about the patient, and then based on that, do whatever is needed to do. So that seems like the biggest time waster that
that's
can
part
be
of it.
The easiest.
And typing the consultation. There are a few AI companies out there that are doing that, right? That are listening to your consultation and then maybe creating a template or a draft of what they think you would like to record. So that would save a lot of time.
That one is getting very popular recently. There is a couple of companies, more in US than here. In fact, there is a French one that I was looking a bit into. I think it's called Nabla. It's quite Nabla, nice. Yeah. They're looking into that, and that is a very straightforward use case for AI, because you have the AI that's doing the speech to text, which is at this point like fairly advanced. It makes like a mistake 1 in 100 words will be a mistake, and it's not that important, especially if you fine tune it for clinical use cases. And then after that you have this other AI that is structuring the speech to text, so basically the transcript, to a nice format, to a nice document that can be easily saved, presented, and whatever else. And even what I think even more that can be and should be done is not simply structuring the document in a nice Word document or nice Word template, but would be even better if that is then distributed into databases so that specific information is extracted from those documents and put into the right place in a database, so that exactly what you were saying now, when you are checking a patient's history, you check what medication was dispensed. Maybe in the same way, instead of you reading through hundreds of documents or clinical letters or something, maybe you just need 5 seconds to check the symptoms of this patient. So you click give me all symptoms, and you end up with basically all symptoms that were queried now from a database somewhere.
Yeah. No, that would save a lot of time. I think the other thing is, it's entirely feasible if you could do that, speech to text and lay it out as a template. You could easily pre-order the tests, or at least, fill in all the details of the test, and then they can ask the clinician. We overheard you talking about, head injury and a head scan. We've actually filled in all the details. Do you want to request it? And then it would just take one click, rather than me going through every single step and filling in all the different aspects.
Yeah, that is, I think, one of the most straightforward ways. Everything there that is related to summarizing the history or summarizing the current state of the patient or transcript of what you are talking with the patient and so on. But I wanted to know there, like, are there currently any kind of AI tools or ML or almost even any kind of software that is currently helping you? Like, that you are currently...
In my day-to-day practice?
Yeah.
We use an image one for stroke. It's called the Brainomics imaging. So that's vision AI, and that's very much when someone comes in with a stroke, we do a certain kind of scan, which is called a perfusion scan, to look at the blood flow and blood supply in the cerebral arteries, and if there's any blockages. So an AI has been implemented within that framework, and they can tell the radiologist and the clinician if they see a clot in the artery, which would mean they may need something called thrombectomy, so a procedure where a clinician can go in and essentially retrieve that clot from the blood vessel. So there's an AI for that, but that's quite niche. There's also AIs to work out the volume of a bleed in the brain. But once again, very niche use case. There, as far as I know, there have not been any AIs that work across departments, that are implemented right now in the NHS, or where I'm working anyway. It would be really great to actually test out some of these voice-to-text AIs. It would be great to actually see how well they work.
Yeah. And in general, like, are there tools that you are using to help you diagnose patients, or any other? Is it mostly you sit down, read through stuff and think about it and do a diagnosis or give a medication, or are there tools that you use for that?
Yes. So you're talking about general tools, not just AI? Just
Yeah,
anything
even
in
now.
general?
Yeah, even general software, any computer
Yeah.
stuff.
So there are tools I use, but they're more clinical risk scores so there's an app for all of these different scores. So I guess it's not the app it's not the computational aspect that I use. It's more the research that has led to these scores. But actually, I did want to talk a bit about this because I don't think I went in depth about the prognosis part at the start. So after you diagnose someone, we're very interested in prognosticating them, in a way predicting the future, because what has happened once in the human body is very likely to happen again for most diseases. Obviously, if you have, an infection, you've just had an infection, but a lot of the diseases that you have a predisposition to because of blood pressure or your lifestyle, or if you've broken a bone, you're very likely to break that bone again because it's weakened. You're more likely anyway than you would otherwise. And likewise, if you've had a depressive episode or a previous breakdown or psychotic episode, you're way more likely to have it again. So we not only are interested in treating what's happened here and what the patients come in now, but a good doctor should very much focus on preventing this from happening again. And I really wanted to touch on kind of the history of this actually, and maybe give an example. So when patients have something called atrial fibrillation, we've talked about, this is an irregular heartbeat. So normally your heart beats regularly, right? So it goes, lub, dub, lub, dub, lub, dub, like very regular. And this is basically physics. If it's going regularly, imagine it's a river and you're percussing at the end. The river will flow smoothly if the rhythm is constant. Whereas if in the disease of atrial fibrillation, your heartbeat is irregular, which means each time you pump blood, it's not going regularly, it's going, completely chaotic. And in many ways, if you imagine it's a river, and with each push, if you're doing it irregularly, you're going to get a lot of turbulence. Does that make sense?
Yeah, of course, yeah.
And with turbulence, it becomes very dangerous because you're more likely to form clots. So when you have atrial fibrillation, you're much more likely to form clots, such as stroke or myocardial infarctions. So there has been a lot of work in the last 20, 30 years to try and prevent that. So if you're diagnosed with atrial fibrillation, there was a study in, I want to say actually early 2000s or late 90s, where they worked out a score. Actually, let me try and find this score. But essentially, it's called the CHADS score. So they worked out that if you have atrial fibrillation and you have these other risk factors, which is congestive cardiac failure, so heart failure, hypertension, if you're aged over 75, if you're diabetic or you have had previous stroke, then you have a much higher risk of having another stroke in the future. And if you tick enough of the criteria here, you should be started on blood thinners. Okay? Mm-hmm. So that's, I think that was the late 90s. But then this highlights an issue because who decided that these were the criteria, actually? And I think this study was only based on just over 1,000 patients. So as time went on, they realized there are more risk factors. So now instead of CHAD, CHAD, it's now CHAD's VASC. So they've added on a bunch of other risk factors for the acronym. So they've added on vascular disease, so any peripheral artery disease, any myocardial infarction, any heart attack. And then, so age over 75 was something in the initial risk factor, but now they've added age 65 to 74. And then they've also added a sex category, a gender. So if you're female, you're also at higher risk. And then these scores change over time with our understanding and our knowledge. Sometimes I just wonder, what are we not picking up in the risk factors because we didn't know to look for it? Does that make sense? Because everything historically has been feature engineered. Someone has thought about the risk factors and they've looked at those things in the study. There could be more factors that are as important or more important, which we haven't looked into. Because it's very hard to do a clinical trial taking into account every single high dimensional aspect of a patient. I think this is something that machine learning and AI would be really useful in, to try and tease out more of these different aspects.
Yeah, no, that one's for sure, because I do think this goes again a bit, this is for sure AI, but it goes outside of large language models or similar things. I think here we can use either simpler algorithms or statistical based methods where we simply want to see what is influencing a certain event in the future, or why is something happening and all of that. But I do agree with you. Like, I'm always very skeptical of any risk score of anything that is basically produced 30, 40, 50 years ago. I'm thinking like, okay, sure, it can be fine, but I don't know, I feel like we should be improving things over time. It is impossible that, like you said, even for the CHAD score, it is impossible that in the 90s, which was obviously proven later, it was impossible that we caught everything and now we have a perfect risk score. Later we upgraded that, and for sure in a couple of years or decade or whatever, we will update it again. So I think AI can speed up that process so that we don't have to wait 30, 40, 50 years to do something like this, but we can have that sooner and faster.
Yeah. And actually, there's, similar story. There's a story called the Q-risk score, which is the 10-year risk for cardiovascular disease, which the GPs use a lot of. And it's gone through many iterations. So, it started off as the Q-risk, and then Q-risk 2 came out, and now very recently Q-risk 3 came out, adding on more factors. And it just makes you wonder, will this just keep going up? Well, we'll be at a point where it's like Q-risk 20.
Yeah.
I do think this is a space where machine learning and statistics can be really useful to tease out more risk factors.
So I think this is the perfect place where we can introduce Foresight.
Yeah.
Foresight is a model that we have been working on. Is basically an AI that we've been working on for the last maybe 3 years. Plus it is building, of course, on work from before that and all of it. So, but it is imagined as a general risk predictor. So what you were just mentioning now is that you have many of these risk scores for many different things. And the idea with Foresight was, can we just skip this so that we have one that is doing everything, and that it is doing it in a way that it does not consider 1 or 2 or 5 factors or something, but it considers everything at once. So you just feed the whole health record, the whole medical history of a patient, the text plus the blood stuff plus any kind of lab tests plus even imaging. You feed all of that into one AI model, and it predicts you the future for that patient. So it basically simulates what will happen with that patient in terms of what diseases will they have, what symptoms will appear, what's even a good medication to give them, what's a good procedure to do on them. So it's doing all of that at once.
Yeah, that sounds amazing, but that's very ambitious as well. Is it possible? Because there's so many different patient groups and so much noise in the data. Is that actually doable?
So we are on the right track to prove that it is. We have already published one paper there, so Foresight version 1, where we showed that even just by using a text, so extracting from the free text portion of a health record, we use text just because text is probably one of the richest sources of information. You can get symptoms, medications, diseases, any kind of substance, any kind of procedure that was done, everything. You can get all of that out of the free text part of the medical history for a patient. And then what you do is you organize these, we call them biomedical concepts, you can call them medical events or whatever you want. You organize them into a timeline. So a timeline in this case simply means these biomedical concepts are ordered in time. And you feed that into a large language model and you use it to predict the future.
That's very interesting. So you're basically saying these large language models that we've covered in the previous episode that predicts the next word fundamentally, instead of words, could we replace them with a timeline of medical concept? Is that correct?
Yes, I would say that we can go even a bit higher and say that these, I don't want to say now large language models, I will say transformers, because large language models are based on transformers. So a transformer trained to do language modeling is a large language model. These generative transformers are, you can even consider them universal sequence learners or predictors. So a sentence is nothing more than a sequence of words. Sure, every word has a meaning and depends on the stuff before and after it. If you look at a sequence of biomedical events like diabetes, then hypertension, then some medication, then a symptom, then whatever, you can really see the similarity because it is a sequence of concepts. You can even call them words, some kind of a token, multi-words, and each one of them depends on the ones around it. So it is a very, very similar task between language modeling and in fact modeling of the medical history of a patient.
But sentences, I'm just playing the devil's advocate here, but sentences and the way we communicate has a certain structure that is frequently repeated. You know, that I feel like the way we speak to each other is probably easier to model than diseases occurring in a person's lifetime.
It is up to us to see. I even have the feeling that there is more regularity in a sequence of diseases. Like if you are taking a typical person, not a special case with a special disease or rare disease or something like that, the path is like fairly standard. For most people, it will be at some point a bit of diabetes, a bit of hypertension, occasional lung disease or something. So it is like there is not too, like, how much variation is there when you're looking at the general population, excluding the special cases? Is it? So I think like it is not, maybe, I don't know.
It's difficult because when you talk about the general population, yes. If I'm working in the emergency department, common things are common, and that can probably be modeled. So especially if there's a catastrophic event. So let's say with COVID, if you're working in the emergency department or acute medicine, you could be pretty sure each day you'd get, a dozen COVID patients come in. But life still happens. There is randomness in life. Like fires can happen, people with burns. I mean, car crashes are relatively common, but people coming in with the first presentation of cancer, that can happen. And sometimes there's not always a clear preceding event. So for things like heart attacks and strokes, yes, usually you're right. They'll get older, 40s, 50s, develop diabetes, hypertension, atrial fibrillation, and then come in with a stroke. But you also get young strokes, people in the 10s, 20s, 30s, people with cardiac abnormalities who have had zero contact with the health services for their entire life, and then they come in with a stroke, not being able to move half of their body. I'm curious, how would you model that? Because there probably isn't much data actually, to model that.
No, but yeah, in that case, of course, it is we were now giving an example of a young person coming in with a stroke that doesn't have contact with the health system. It is impossible to model that. Like how would I model someone that I've never seen? So that, of course, is impossible. What I even think, even in that case, is that it will be possible in the future. Not by interaction with the health system, but I know by using smartwatches, by wearables, by whatever else. And over time, you will find those patterns in someone's heart rate. Maybe that person had AFib before and just had no idea they have it, and it's not, then the stroke is not that strange. So I think with wearables and similar, we will be able to do that. And then the machine learning again makes perfect sense there. AI models make perfect sense because you can apply them population-wide. Yeah. And
genetics, right? If the parents have a genetic problem or have certain diseases, that there's a high chance the children will inherit it.
Yes, and there was this other example here that you were giving is, what if it's a rare disease? What if it's a special case? That is much more difficult because there is not enough training data. But that is why you approach that from a slightly different perspective, or at least how I've done it now, because what I've noticed also with Foresight version 1 is exactly what you just said. If I had enough data, like for COVID, which we had millions of examples, or more common disease or something like that, we got very good at predicting them. We got like 99% precision accuracy, however you want to call it. We were extremely good at predicting that in the future of a patient, especially for COVID. Someone comes with a couple of symptoms similar to cough, and then there is also like loss of sense of smell or something. It's okay, that's COVID immediately. So it got easy. But what we also saw is that for rare diseases, it did not work very well. And how we decided to circumvent that is by learning from different sources. So you can, of course, on one side learn from the patients, so real data, which I think like this is what I was mentioning initially that is currently missing, is learning from real data. A lot of these LLMs focus on books or whatever, questionnaires, but don't focus on, in this case, hospital data where you are predicting the patient trajectory, so the timeline of a patient. So what I understood, in fact, with Foresight 2 is that we need a mix. Not one is enough. You cannot simply only learn on patient trajectories or timelines, but you cannot also only learn on the questionnaires. If you combine especially for rare diseases, there is an enormous amount of literature. Like rare diseases often have a lot of papers published on them. So if you train your model on those papers and then fine-tune it on the couple of use cases that you have, so a couple of patients that you might have, the model learns much faster because it already knows quite a lot about the disease. Now it is just the same as a doctor. You would learn from books, and then once that disease appears, you will learn more about it. You will learn what is happening in practice. And the same is here. First train a model on MCQ and UMLC or any other type of data, any other type of medical data, books or whatever, and then fine-tune it on the real world examples.
That's very interesting. So it's very much like ChatGPT goes to med school. It's passed the USMLE. Okay, now let's expose it to real world practice, just like a junior doctor.
Yeah, exactly that. Yeah, this is now Foresight version 2, which should be out in a month or two, where we are just showing how does it work when you combine these. And then in the future, we also want to expand that. We want to expand it so that it's also taking images as input. So as I mentioned, for now for now it's just text, images, lab tests, whatever else.
But just a slight tangent. Like, I completely agree with you. All of these newer large language models, they're all just based on data available online, textbooks, things like that. It's really surprising to me how so far none of the big tech companies have tried to do what we're talking about. I find it really strange. Like, in our team, there's only a couple of us pushing forward this research. In Google, they have, I don't know how big the MedPalm team is. I saw in the paper there are dozens of authors. Why aren't they doing this? I don't know if you had any thoughts.
It's a good question. It is hard to answer. There is many of these questions. I'm also asking myself, why did Google not make a better assistant before? You have this Google Assistant that's a complete mess, that doesn't work at all. Why did they not have more people working on that and make it better so that it better understands speech? Or even Siri. Like, you have Apple that has millions of people and that has...
I don't want to labor this point too much, but yeah, I guess...
No, but I agree. I think there is many reasons. It can also be that accessing the data is hard, because here you really needed the hospital data to be able to do this. It can also be that they are thinking this is too much in the future. There are more pressing things to address now. Diagnostic and prognostic tools, I do think they will come a bit later, or AI will help doctors in that area a bit down the road. So it will take us a bit time to really do this properly. It's much harder than the text summarization. But I think it would be useful, at least for our viewers. I'm sorry to the audio listeners, to check out a quick demo. And I'll just show also maybe one slide of how does Foresight look like, and what is in fact this patient timeline that we are talking about, and how it is prediction working. Okay, so here we have a patient timeline. Like, what is that? So it is simply, we have some patient X, and for that patient we have a stream of biomedical, a sequence of biomedical concepts ordered in time. So we have that age 68, the patient had restless legs, and then hypertension a bit later. Then at 71, insomnia, and so on. And then all of that feeds into this large language model called Foresight, and then it can be used to predict future diseases, symptoms, medications, whatever else you want. And this, of course, doesn't have to stop at one point, but you can basically, with such a model, you can, because it is a generative model, a large language model, you don't have to predict just one step into the future, so just one disease into the future, but you can continue simulating the patient's future almost until the day they die. So almost you can just continue simulating until the model predicts patient has died, and that's it.
That sounds quite dark, but but yes.
Yeah. It is a bit scary, but it is still useful. It doesn't work very well when you go very far into the future. This model works usually very well when you are like under a year in the future or something like that. The further away you go, the more randomness in it introduces and more uncertainty, because in general, like, it is also not possible. You cannot predict someone's future health based on the first, 20 years of their life or something like that. So it is difficult. And just
gonna have a look at this this timeline then. So so this is the first thing we have is the gender and the ethnicity. Genomics would be useful, and then so at age 68 they developed restless leg syndrome, and then hypertension, high blood pressure, and then at 71 insomnia, and then had an x-ray whilst they were in the hospital, I presume. 74 had a fall and some findings in keeping with small vessel cerebrovascular disease. And then later on they developed visual hallucinations and constipation. Age 77, delirium, memory impairment. Okay, and then this is where you put the Foresight model into work, and it's predicting, okay, based on that timeline, what is likely going to happen next. And they've predicted Parkinson's disease, and then what's the last two?
We have
periodic limb. Sorry, I can't read that.
Periodic limb movement and sleep apnea.
Yeah. Interesting.
And this is just one of the examples. Of course, you can do this with any kind of medical history. And what also this allows you, or what these models that can simulate the future allow you, is to test out things, to do like A/B testing. Because at this point you can do, for this patient, I could try to add a medication A, and then see what will happen in the future. And then add medication B, see what will happen in the future. And based on that, see like, oh, maybe this medication will have a serious side effect or will have a negative effect or something, while medication B is much better. It is, of course, any decisions should not be made simply based on these, but it can be an informative addition to the current way diagnoses are done. Yeah,
I mean, this is very much a proof of concept to see what's possible.
Yes.
Sorry, just one sec. Do you have another example?
Yes,
Or is
so
this the main timeline?
we can look at other examples that are now much more, so that are running in this demo. You can basically access this demo yourself on the Foresight web app and try things yourself. So on the left, we have a couple of examples. So pre-populated things that you can try. So we have one for COVID.
Okay, should we look at this first?
Sure.
So a white female, 45-year-old with type 2 diabetes, stomach ache. And then at the year after the age of 46, they developed loss of smell, cough, and a fever. So let's predict what's the most likely. It's predicted it could be a rhinitis, could be a common cold, could be COVID-19, or an upper respiratory tract infection. Yeah, so that's fascinating. All of those are quite sensible differentials, I would say, in someone who's come in with that set of symptoms. I'm not entirely sure what the stomach ache finding is for. I don't think that, to me, that has no bearing on the diagnosis. Could we try removing that and see what the model says?
The timeline is simply everything that appeared in the patient's history. It can be the stomachache was related when they were age 45 and something was happening, or they reported that symptom.
Yeah.
The COVID example, of course, is a very simple example. We can have a look at something slightly more complicated. So let's have a look at the following patient.
Let's see if I can guess the diagnosis. So it's a 46-year-old male, and then with obesity, and then 2 years later developed type 2 diabetes. At the age of 55, became tired all the time, headache, and then a couple of years later developed daily headache, hypertension, gastroesophageal reflux disease, had poor concentration, migraines, and depression. That was a bad year for this guy at 58. And then at 59 developed chronic tension type headache. So essentially you have a gentleman who over the course of 5-10 years, who's obese, developed diabetes, became tired, developed headaches, poor concentration, and depression. This is quite a tricky one, but I would think the tiredness and the poor concentration and the headaches may point towards something like sleep apnea. So maybe this gentleman had sleep apnea, or was just very unlucky and had multiple coincidental diseases. Let's see what the model says. So yes, obstructive sleep apnea is number one, and sleep apnea. And then here it also says, he could have just a tension type headache separately, because that is a very common diagnosis in the population. That's really interesting. I mean, the fact that it even works is fascinating. I think it's going back to the conversation we had at the start, Zeljko. Like, it's, we've seen large language models model language and predict the next word. It's fascinating to think that there are these patterns embedded within the population, and that diseases actually follow some kind of temporal pattern, just like words in the sentence. Can we do one more?
Yeah, no, of course. Okay, we should do, for example, this one. I think this is slightly more simpler, but slightly hidden diagnosis.
Okay, so 38-year-old male with hypertension. Over the course of the next 3 years, developed CKD, chronic kidney disease, so no surprises there. At the age of 43, on examination, the kidney was palpable, and he developed a thunderclap headache. So this is a very sinister type of extreme headache that's severe, 10 out of 10, sudden onset. Age 46, microscopic hematuria, so blood in the urine. And then at 48, frank hematuria, so a lot of frank blood in the urine and loin pain. Okay, so based on that history, you have a very young gentleman who developed high blood pressure very early on, and then had CKD, so worsening renal function. I think the thunderclap headache would warn me towards something like a subarachnoid hemorrhage or an aneurysmal bleed, which is very common in patients with adult polycystic kidney disease. And I think the palpable kidneys would point towards that. So is it, can we see, is it a syndrome? Is it polycystic kidney disease? Yes. So here we have autosomal dominant polycystic kidney disease.
Nice.
Lovely.
Yeah.
That's great.
This of course in all of these timeline is very important. So it is also, this one is checking, can the model look into the past? Does it understand that something's happened when they were 38 years old, something's happened when they were 43 years old, some things can really be just an occasional instance of something, so it doesn't have to be like, I don't know, the thunderclap headache. It can be that it only happened once and never again. So that this is just like looking, can the model understand the pattern and maybe understand that maybe some things are more noise than really the signal that is telling you what is the right prediction, what's the right diagnosis.
And all of these diseases were extracted from the healthcare records from King's College Hospital using named entity recognition, MEDCADs, which we talked about in the previous episode. Is that right?
Yeah, exactly. All of these was extracted from the free text, and this model Foresight was trained. We can of course go through more examples, but I don't think if someone wants to play around, it is easy. You can, instead of this, you can also have a look at the full-on part where you are writing some text. So as we just mentioned, Foresight is a combination of a couple of tools. So there is this large language model that's doing the prediction, but there is also this MEDCAD part that is doing the extraction of concepts, so the NER part. And these can be combined into a pipeline, like in this example here, where we are now writing in text something like a 25-year-old man complains of cramping and abdominal pain for 2 weeks and so on. So we write out basically a clinical note and ask for a prediction, and then we will still, the model will now automatically go through that, find the right concepts, extract everything that's needed, and still do the prediction. So in this case, it's a patient with Crohn's disease. But yeah, a bit too much to read all of that. You can have a look and play around on the Foresight web app. We'll leave a link in the description. Yeah, have a play around. It is really fascinating, and I would love to do a test actually to see if it comes to the same conclusion. Let's say a patient came into the emergency department. I'd be interested to see if it could come to the same differentials as the admitting doctor. But that might be a bit difficult. Yeah, I don't think it is still at that level. Like this one, the Foresight version 1 was to prove, is this even possible? So the now one that we are working on, the version 2, it will be much better, or it is already much better. This one was simply to see, can this even be done? Because something similar was not really done before. Someone using a generative model on patient timelines, especially extracted from free text and basically automatically generated. It is a novel approach, so we just wanted to see, is this even possible? And this proof of concept here, as you mentioned, is just to show that, okay, it works. We can, it's a good direction, we should and we can continue building on it. And that's why we will now have Foresight 2 and then 3 later and so on.
I'm curious, what have you actually changed in Foresight 2 to improve the performance compared to Foresight 1?
So I think one of the main things, as we were talking a bit earlier, was simply that we are not only using the health record. So we are not just extracting concepts from the health record, but we are also using the data from medical textbooks and everything else that has a connection with medicine, so that the model gets more knowledge inside. One thing with all of these language models, or with in fact any model, is that, for example, if we train a generative pre-trained transformer, so a GPT-like model, on only the patient timelines, the model just on those patient timelines has to learn what's a disease, what is a medication, how is that medication used for what. So it has to learn, it has no knowledge at all. So it's basically an empty model, and has to learn everything about medicine that exists just based on, I don't know, it can be 10, 20, 50,000 patients. And that is not enough patients to learn everything that exists about medicine. So you need more input, you need more data from books, from quizzes, from questionnaires, from anything you can imagine, from random public data. So anything you can imagine should go in so that the model can learn more about medicine, and then combine that with the patient timelines.
Yeah, fascinating. So you're enriching the model with more kind of intrinsic knowledge of medicine through textbooks, through papers and things like that.
Yeah, exactly that. Yeah, there is a couple more updates, but I think it will become very, very technical. So we'll skip that for now, and whoever will be interested, there will be a paper for that, so you can have a look at that. I think that we have covered quite a bit today. We went from what is a doctor's job to basically doing diagnosis with AI, which is a bit into the future, but hopefully we'll get there also soon.
Yes.
Thank you very much for listening. Consider subscribing, and we'll see you next time. Bye-bye.
Bye. See you on the next one. Bye.
Thank you very much for listening. Everything we talk about, everything we will do here, we will try to cover all the different aspects that can help us improve healthcare.
Those are lofty ambitions, but I hope we deliver.
Subscribe, and we hope to see you next time. Bye-bye.
See you on the next one. Bye.